Hi, I'm Dr. Matt Brinkman, and I'm going to talk to you a little bit about gastroparesis today. I do gastroparesis therapies in my practice. About 50% of my practice is gastroparesis, and it's an unusual therapy. I think I do some talks nationally for this, and I did one in the summer of 2015, which we broadcast on Periscope, which some followers on Twitter saw. And there were some people who missed it. And, if you know Periscope, it kind of goes away after 72 hours. So we thought we'd put something together, put it on the website, and hopefully this is informative to you. First thing we probably should do is just define what gastroparesis is. Gastroparesis is a slowing of the emptying of the stomach that's not related to a blockage. Clearly, if there's a mechanical blockage of the first part of the intestine or the end of the stomach, by a tumor or scarring, that's going to lead to gastric slowing. But that's not what we're talking about. What we're talking about is somebody who appears to have a normal stomach, but it's not emptying properly for a functional reason. So delayed gastric emptying can lead to all kinds of symptoms. And generally speaking, people experience bloating and fullness, nausea with or without vomiting, acid reflux, and abdominal pain. Now, you think about those symptoms, they're pretty generic. There's lots of different things that can give you those symptoms. You can get those symptoms from gallbladder disease, gastritis, hiatal hernia, H. pylori, gastric ulcers, duodenal ulcers. So the problem with the upper abdomen is almost everything gives you those types of symptoms. And so generally speaking, people are going to go through a long process of self-treatment and then some diagnostic workup by their doctors before they get diagnosed with gastroparesis. The underlying cause of the slowing is what we're a little more interested in. Slowing is basically a symptom of other disease processes. We think of gastroparesis as being diabetic and non-diabetic. Non-diabetic has another term called idiopathic, which means we don't know what causes it. When we look at diabetics, about 5% of the type 1 diabetics will develop gastroparesis that's symptomatic over their lifetime. About 1% of type 2 diabetics will get it. Now, diabetic gastroparesis is a type of neuropathy. And so for the diabetics out there, you know neuropathy can mean painful feet, tingling in the feet or the hands, and other types of like retinopathy. So it takes a while to get it. So most people are going to have diabetes for about 10 years or more before they develop significant gastroparesis. We don't think of it commonly in people who are just diagnosed with diabetes, unless they've been untreated for a long period of time and they just come to therapies. That's not most people in this country. For the idiopathic gastroparesis, it's a much smaller number. It's about 0.2% of the total population. But there's just way more people that are non-diabetic in this country. So in all, there's actually more people with idiopathic gastroparesis out there than there are diabetics. Unfortunately, most physicians don't think of it as being a very common disease, and they'll think of diabetic gastroparesis when a diabetic comes in with nausea or vomiting. But because of all the crossover with other diseases that are much more common, again, gallbladder disease, ulcers, gastritis, etc., they won't think of gastroparesis as the first item of interest when a patient presents with those symptoms. Diabetics and non-diabetic or idiopathic gastroparesis, they present differently. They're kind of different disease processes. And so the diabetics tend to have more nausea and vomiting, bloating symptoms, but less pain. The idiopathics tend to have nausea with less vomiting, but a much higher incidence of epigastric abdominal pain as a component. And so that's pretty clearly seen when we look at these populations. And so that can help direct somebody when they see a patient with these symptoms. A common statement I hear from the patients I see is, I've had pain for so long, my doctors aren't trusting me and my symptoms, and they say that pain doesn't come with gastroparesis, and that's clearly not the case. If we look at the literature around gastroparesis, especially idiopathic gastroparesis, 80 to 90% of patients who come to medical care for gastroparesis will complain of abdominal pain as one of their symptoms. Now, A much smaller percentage, only about 20%, are going to have that as their primary complaint. But if you do a good history, they'll describe nausea, vomiting, bloating. Oh yeah, I also get pain after I eat. It's just not the primary presenting symptom. So the purposes of this conversation we're having, we're going to divide gastroparesis up into kind of three big buckets. The diabetic gastroparesis, and then the idiopathic gastroparesis we're gonna put into two subgroups. There's postviral and then the postsurgical. They're treated slightly differently, and so it's important to try to figure out who has what. As I mentioned when we were talking about incidence, the biggest number of patients is going to be the idiopathic gastroparesis. These are typically middle-aged women or younger women, 35 to 45 at presentation. Many of them are going to have an antecedent or preceding viral illness, whether it's respiratory or gastrointestinal, the flu, for lack of a better term. And then after that, develop significant nausea, vomiting that sometimes leads to hospitalization, and it just persists. It keeps on going on. And then the physicians are sort of at their wits' end to try to figure out what's going on. That's the most common presentation. When we look at post-viral gastroparesis, there's been lots of studies. The one thing we know is it can get better over a year, and some people are going to experience spontaneous remissions. And so typically, as somebody who does gastroparesis therapy as part of my work, I'll wait on those people until they've had to, just to make sure it's not going to get better on its own. Now, most people who come to me have had symptoms for multiple years, and so we know that they're not going to resolve spontaneously, but some don't, and for those we wait, and we do other therapies that you'll hear about a little bit later in this talk. There's been some studies on looking at the viruses that can cause this. Cytomegalovirus or CMV, Epstein-Barr virus, herpes or herpes zoster. Those can all be associated with the development of gastroparesis. And so if you have had those diagnoses and now you're having significant abdominal pain or nausea or vomiting, there's a possible link there. Less common in numbers but dramatic in presentation are the folks who have post-surgical gastroparesis. And that's a physical disruption of the nerves that go to the stomach at surgery. And this used to be really common with ulcer surgery. Back 25 years ago, we did a lot of surgery for ulcers. And one of the major procedures that was done involved dividing the nerves that go to the stomach. Now, we don't do ulcer surgery that frequently any longer because we have great medications that allow us to not have to do it. But we do other surgeries where we work around the food tube or the esophagus, and we're working on these nerves. And those are mostly done for gastroesophageal reflux disease or heartburn, and then hiatal hernias. And, if you just look at the surgical series, there's at least a 1% incidence of damage to these nerves during these procedures. They can be hard to identify. Sometimes the anatomy is very abnormal when these procedures are being done. And if they're damaged, they can lead to significant gastroparesis symptoms. A final cause of gastric slowing that's not really gastroparesis is drug-induced gastric slowing. This is clearly most common with the narcotic pain medicines like Percocet and Dilaudid and morphine and the others. Narcotics have a direct effect on the bowel and have direct slowing of the bowel. So somebody who's on chronic narcotic therapy, most commonly for back pain, those people can often see chronic constipation and chronic gastric slowing. And the mainstay of therapy there is to see if there's another medication that could work versus the narcotic. Because if you can get them off the narcotic, many times it'll just get totally better. There are other medicines that can do it too. Anticholinergic medicines, those are mostly antiemetics like Phenergan and Compazine, scopolamine patch. Cyclosporin and antitransplant medicine will do this the same. And interestingly, a medicine called Byetta and the other GLP-1 analogs, these medicines are used for diabetes. They are a synthetic form of a naturally occurring hormone that the intestine makes that helps your body digest and absorb glucose and sugars from your body. And we know that through some studies that were done a long time ago that direct infusions of that hormone cause gastric slowing. And so the main side effect of Byetta is gastric slowing and nausea. And so we use it in diabetics. And so some diabetics have gastroparesis. Now we can exacerbate it by using one of the medicines. So if somebody who's a diabetic gets put on Byetta and they start vomiting like crazy, or they have a lot of food intolerance, they're going to need to come off that medicine and try a different medicine. And the symptoms will resolve with cessation of the medication. So how do we make the diagnosis of gastroparesis? Well, the gold standard really is something called a gastric emptying study, which in this day and age is a pretty vague test. It's a nuclear medicine test. So the patient eats either like an egg salad sandwich or some oatmeal. It's been labeled with a radioactive protein. And they sit or lay down in front of a big Geiger counter, for lack of a better term, just a big disc. And it measures the radioactivity in the stomach. And over time, we see that radioactivity decrease, and we know that the food is moving through. And typically, we want to see about 50% of the radioactive material move out of the stomach in a 4-hour period. Ideally, the test is done over 4 hours. Lots of time it's done over 2 hours with extrapolation out to 4 hours. That's fine if it's really abnormal, but if it's close and there's some concerns, then probably a 4-hour study is the best thing. There's some other tests that have been done. They're really not the gold standard. There's breath testing. There's wireless capsules where you eat a capsule and you see how long it stays in the stomach, and the change in the pH that's sensed by a remote sensor tells us. Endoscopy can be quite helpful though. So if you have to have an endoscopy for any reason, and nausea is a good reason to have an endoscopy, and your endoscopist goes down into your stomach and they've made sure that you didn't eat anything overnight, so it's been at least 12 or maybe 18 hours, and they see that your stomach's full of food, almost by definition, unless there's a medication causing some sort of a side effect, that would be diagnostic of poor gastric emptying. There's some pictures you'll see on these next slides of images of what a gastric emptying test look like. You can see it's not super scientific, but it's what we have, and it seems to work to get people in the door for the diagnosis. Then it's really up to the clinician to say, okay, what kind of gastroparesis is this, and how are you best going to treat it? Treatment of gastroparesis is multifactorial, and honestly, the majority of patients are going to improve with just dietary therapy. So avoiding the foods that slow the stomach, and then not eating large meals so the food has time to empty, although slowly, before it causes any side effects. So typically we'll tell patients to avoid raw fruits and vegetables. That tends to slow stomach emptying. Caffeine, high-fat foods. That can also mean spicy foods, because most spicy foods, even if they're not perceived as high-fat, they have a lot of oil in them to carry that spice. And then things like smoking that also decrease gastric emptying. So you want to take all the confounding variables out. Small meals, maybe 5 or 6 meals per day. Liquid to softer based. Majority of patients are going to do fine with that. Does that mean that patients are going to eat that all the time? No, that's totally unrealistic, right? So people go on holiday and whatever, but then they can manage it, right? So if they say, look, I'm going to have pizza because I want pizza, I know I might feel bad afterwards. They make their choice, but they have the tool to manage their symptoms. And so dietary therapy is a mainstay. And basically every patient with gastroparesis should see a dietitian with some expertise in the disease, just to go through their diet and see if there's a way to manage the disease without even using medications. One of the reasons that gastroparesis is really, relatively shunned by many physicians is we don't have great drug therapy, right? So if you're in your office and you're a primary care doctor and you are seeing lots of different diseases, you want to be able to treat them. And when you can, it's hard. It's hard for the patient. It's hard for the physician. Right now, we only have one FDA medication that's approved for gastroparesis, and that's a medicine called metoclopramide, or the trade name is Reglan. Unfortunately, it has a black box warning around it. So anytime there's a black box warning, physicians don't really want to prescribe it too much because there's some liability. And there's a lot of side effects, right? So Reglan, it can be very effective. It's usually very effective when people initiate therapy, but there tends to be some accommodation to the therapy where the effect wears off over time, leading to increasing doses. And there's a dose-dependent side effect profile that involves involuntary movements, facial motions, jitteriness. And if those things occur, the medicine has to be stopped, because if it goes on prolonged, those side effects can become permanent. And so very important to recognize those limitations. And when they are recognized, get the patient off the medication as quickly as possible. Unfortunately, then, what are you going to do for them? Because they were sick enough to need medications. What are other choices? There's a medicine that's available outside the United States called domperidone. Was kind of available in the United States for a while through overseas pharmacies in Canada and India and Australia. The FDA has really come down on the people that were importing this drug, even though it works pretty well and it's generally pretty safe. It's not FDA approved, and the FDA finally did kind of come down on several pharmacies and practitioners, and so much more difficult to get than it used to be. And so while we still see people use it, not quite as much as we used to. There's a side effect profile too. Probably the most important one is that it elevates the prolactin level. There's a rare incidence of pituitary tumor formation, and for women that can mean that they start lactating. And if that happens, clearly the medicine needs to be stopped, even if it's beneficial. Some medicines that are used in the hospital more are medicine Erthromycin, which is an antibiotic. It is structurally similar to a molecule in the body called motilin. So it has a direct effect on the stomach to increase emptying. It's why the major side effect of erythromycin is nausea, because people get this sort of hyperactive stomach nausea and they can't tolerate the medicine. Well, for somebody whose stomach doesn't empty very well, erythromycin can be beneficial. It works pretty well IV in the acute setting. There's very rapid accommodation to the effect, so it generally won't work longer than about 4 weeks. And so prescribing it as an outpatient typically is not going to work for most people, although it generally is tried. But it can be helpful in the hospital. So if somebody comes in with an acute gastroparesis exacerbation, IV infusions of erythromycin are indicated and can be helpful, and have been shown to be so in some of the medical literature. That's it for the medications, and I didn't say anything that sounded super good, so that's why we are here, I guess, a little bit today to talk about other therapies. The next step in a lot of people's algorithm is to place an enteral tube. So that's a tube that goes in the body somewhere into the stomach or intestine so that nutrition can be delivered by liquid directly to the intestine. It's about as good as it sounds. It can be really helpful in the acute management of people who've had gastroparesis for a long time, who present very ill, very malnourished, not ready to have any type of surgical intervention, or just need to have their nutrition balanced out to see what happens. And I've seen patients in the past who've had acute gastroparesis just have come in very malnourished, immune system depressed from their malnourishment, just sick as a dog, for lack of a better term, brought them into the hospital, got them on enteral nutrition, usually through a jejunostomy tube, got their nutrition back, and have them completely recover, because the malnutrition was just exacerbating the problem so much that you have to sort those two things out. So the person who shows up very malnourished, enteral therapy is really indicated, and probably 6 weeks, a good trial, checking the laboratories, making sure the vitamin levels are normal, making sure the protein levels are normal, getting their immune system back to where it needs to be. And that person can sometimes not need any therapy, and that does happen on occasion. So enteral therapy can be very helpful. Enteral therapy, however, is not what we call a destination therapy. What we mean by destination therapy is a long-term solution to the problem. First of all, enteral therapy requires a way to get the food to the intestine. So if it's not going to be surgically, that means a tube through the nose that goes all the way through the stomach into the intestine. The data on that is just terrible. Those are okay things to do in the hospital where the patient is not going anywhere. But outside the hospital, those tubes are really tiny. They tend to get clogged. They tend to migrate back into the stomach, worsening the problem. You can imagine delivering a bunch of liquid nutrition into somebody whose stomach is not working right. That's not going to be too good. Or they get pulled out on accident. People are asleep, they grab at things, and it just doesn't work out very good. So a temporary therapy with a tube in the nose is okay. Longer than 6 weeks, there's almost nobody who makes it longer than 6 weeks with this kind of therapy. So if we're going to consider doing enteral therapy as an outpatient, like do it, get them home, let them recover, we're almost always talking about a jejunostomy tube. And so you're going to see in these slides, there's several pictures of jejunostomy tubes. A jejunostomy tube is a surgical procedure, typically speaking. Some people will do them at endoscopy, but that's not as frequent, usually with surgery. It's a tube that goes through the skin, and there's a picture you'll see into the intestine. This disease affects a lot of young women. There's a lot of body image issues with having a tube hanging out of your stomach. It's not a good thing, and they hurt. They always leak a little bit. There's always a little bit of seepage around it. Kind of smells bad and it's gross. And so as a destination therapy, it's like not what we want. I mean, sometimes we end up in that corner, but we should have exhausted many other therapies that you'll hear about in a minute before we end up there. So it's good for the short term, not great for the long term. Another short-term therapy, if the patient can't get enteral therapy, is IV nutrition. Total parenteral nutrition, or TPN is what it's called. That requires an implantable IV catheter. That has its own problems with infections and implants. And then the nutrition but just cannot be as balanced as enteral therapy. Enteral therapy is sort of naturally occurring compounds, and there's lots of little micronutrients that we can't create in a bag solution to help. And then the IV nutrition, infections are a problem. So long-term IV therapy should really be a rarity. It's very expensive, lots of complications. The catheters usually have to be changed out due to infection over time. And for somebody who's young, 30s or 40s, we should be looking for another answer for that person than long-term IV therapy, if we can find it. The next therapy, which is not surgical, is injection of the pylorus, or the muscle, at the end of the stomach with Botox. Botox is a naturally occurring compound that, when injected into muscle, essentially paralyzes the muscle. And so Botox makes that muscle at the end of the stomach open all the time. And so if your stomach is not emptying properly, we don't want a valve at the end of the stomach that's closed, right? We want it to be open all the time, so at least gravity will help the food go out. And so Botox injection has been around for a long time. It's been studied on many occasions. There's a lot of controversy about whether it works or not. Yeah, in my experience, I don't do Botox injections, but I see lots of patients who've had Botox injected. It works about 20% of the time. And based on what we know about pyeloplasty as a therapy, Botox injection should work more frequently. And so I think the problem with Botox injection is not so much that it's theoretically a bad thing. I think theoretically it should work. I think it's that it's very hard to deliver from the end of an endoscope directly into the muscle at the right location to get it to relax. I think it's a little bit of a crapshoot, for lack of a better term, to get it in the right spot. And so when it works for people, it's great. When it doesn't work, it doesn't. Typically what I see is for when it does work with people, they get 1, 2, or 3 injections, and by the third, they're starting to get this accommodation to the effect, and it's not working like it used to. And so then we'll pursue with surgical therapy. But it can be, and it usually works for about 6 months. And so I think it's worth doing for people, but I also don't think it's a permanent solution for most people. So now we're going to talk about surgical therapies. Full disclosure, I'm a surgeon, so I know probably more about this than anything else, although I do plenty of other therapies. I treat lots of people, though. I don't think just because you have gastroparesis you need surgery, and most people don't. We already talked about diets and medications, and lots of people are going to be better, or even waiting and doing nothing. Some people will come to surgery. It's a smaller percentage, and we're going to go in the order of history rather than frequency, just to give you a better sense of how things have evolved over time. The first surgical therapy we're going to talk about is gastric electrical stimulation. This is probably better known as the gastric pacemaker. The trade name is Entera, E-N-T-E-R-R-A. It's a device. It was introduced and approved in this country around 2001. I was in one of the initial training classes from Medtronic, the company that makes it. And it's a modified pacemaker. And initially what was thought was we were going to take a modified pacemaker, take some wires, just like we take wires from a pacemaker, put them in the heart, put them on the stomach, turn this thing on, and then the stomach is going to start pumping the food out. And what we know for sure is it doesn't work like that. That this is truly neural stimulation. It comes back to sort of what's the problem in gastroparesis or in some forms of gastroparesis. And the problem is the nerves are damaged. And so what do the nerves do in the stomach? Well, autonomic nerves, or nerves that go to the intestine, are not like our skeletal muscle nerves. Our skeletal muscle nerves, the ones that move our arms and our hands, when the nerve fires, the electrical impulse causes the muscle to contract, and it's the exact opposite in the intestine. When the nerves fire, it causes the muscle to relax. And so you can imagine that in the stomach, if the nerves are injured, then the muscle is not relaxing at the right time. And maybe it even spasms when the patient eats. So, and that's why sometimes we see patients who smell food and all of a sudden become very nauseated and have retching, or they eat like one bite and all of a sudden they're vomiting like crazy. It's not like they had a giant meal and they're vomiting. It can be literally one bite. And so this denervation effect can be very prominent. And the stimulator reinnervates. It gives electrical stimulation to the stomach. And there's certainly a subgroup of people who think that it increases accommodation. That is, it helps the stomach relax when the food comes down. This is borne out by some of the evidence in which, the majority of patients who have a stimulator, their stomach doesn't empty better. If we measure gastric emptying before and we measure gastric emptying after, it's actually the same. There's a minority that will have improved emptying, but the majority do not. And yet the vast majority of people who get a stimulator, 75%, will experience significant improvement in their symptoms. And so we think about the problem as denervation, then gastric stimulation seems to make a lot more sense. Like I said, about 75% of people are going to improve. This therapy is much more effective in diabetics than it is in idiopathic patients. My experience is about 80% of diabetics are going to have improvement, and about 50% of folks who are idiopathic gastroparetics are going to have an improvement. Not that it can't work, but it's not as effective. And so for gastric stimulation, that's my first-line therapy for the patient who has a diabetic gastroparesis, especially the ones that sort of have symptoms that sound like denervation gastric spasm. And so those people generally would do pretty well with a gastric stimulator. And so we'll offer that as first-line therapy, and then we'll progress through therapies if they need something else. Now, the gastric stimulator is a device, right? So it's a battery pack, and it's wires that go through the abdominal wall into the stomach. The battery has a lifetime, just like any battery, the battery in your car or your cell phone. That battery has to be replaced, depending on the settings, between 5 and 8 years after it's placed. And so, you're talking about putting a gastric stimulator in a patient who's, 40 years old. They're potentially looking at multiple replacements of the device. It's one of the reasons now we will commonly use adjunctive therapy or adjunctive surgery with the stimulator, and we'll talk about pyeloplasty in a minute. So most people will now do a pyeloplasty at the same time as the stimulator, trying to get as much effect as possible and maybe decreasing the frequency with which the stimulator needs to be changed. Very few complications with the stimulator. Your provider can give you a lot more detail on this, but it's generally a safe operation done with the video laparoscope. I keep people overnight, but some people will send them home the same day, and that's fine. The next therapy we're going to talk about is laparoscopic pyeloplasty, and this is a relatively new procedure. There's another, if you go to our site, there's another little slideshow you can read through that has a lot more information on pyeloplasty with some references, and I encourage that if you want to learn more. This is a procedure that's been around for about 3 years now, commonly, maybe a little bit longer. And based on some information out of the University of Oregon, was really the first group to publish on this, where they just took a bunch of people who had gastroparesis and laparoscopically they cut the muscle at the end of the stomach. Now, if you think about the Botox data a little bit, you would think it probably wouldn't work that frequently. If Botox is working great, 20% of people respond, then we should expect 20% of people who have the muscle physically cut with surgery should also respond. And I think everybody in the group of people I know are really impressed that it works much more frequently than that. The published data is like 75 to 80% improvement in symptoms and improvement in gastric emptying. So remember, with the stimulator, there was no improvement in gastric emptying. With pyeloplasty, improvement in gastric emptying as well. And so for those folks that have like bad reflux from retained gastric secretions, this is like a better procedure for them. And so I started doing this procedure several years ago. I use it routinely in the idiopathics because those people seem to do better. There's been additional information over the last couple of years on looking at pylorus and pyloric function in patients with idiopathic gastroparesis. And turns out, not surprisingly, that the muscles in the patients who have idiopathic gastroparesis tend to be higher pressure. They're squeezing harder and they're hypertrophic. They're thicker than they're supposed to be. And this may be part of the etiology or the cause of idiopathic gastroparesis. So you eliminate that, you cut that muscle, that spasm or that high pressure that is eliminated and patients feel much better. And so my experience has been similar to that of the medical literature. Many, many people improved quite dramatically. It's a laparoscopic operation. It's an overnight hospital stay in my hands. It's cutting the intestine, so there's a little bit of risk, bleeding, infections, rare incidents of leakage, but it's no implant. So there's no adjustments afterwards. There's no batteries to be changed. And so it has that benefit. So it's a nice little procedure. It works really well for people. There's few side effects. And so we like doing this. And again, I think the consensus opinion now is that even for diabetics who are going to have a stimulator, we add pyeloplasty to that to get the added benefit of increased emptying and see that result. Those two therapies work great together. You can do them sequenced, you can do them together. And then they seem to really improve people's life and get them back onto eating normal foods. Again, the destination for all these therapies is eating normal foods. Now, does that mean chicken wings every night? It doesn't mean chicken wings every night, right? It means maybe chicken wings. What it does mean is that you can eat solid food with your family and not be ostracized to some sort of minuscule diet or boring liquid diets or things that really take away from the quality of life, right? I mean, we live so much of our life around the table. So many of our meaningful events in life are around eating that, it's our obligation to try to help people get to a point where they can eat normally. And so these procedures really provide that. And so it's really, these are good therapies. Now, not every single person is going to get better and with those two therapies. And in my experience, it's really the very severe diabetics who don't have a hypertensive stomach any longer. They have a completely flaccid stomach. There's no emptying at all. We'll sometimes see on the gastric emptying study what's called an ascending curve. They don't see it empty at all over the course of 4 hours. Sometimes even cutting the muscle or putting a stimulator is not going to help those people. And they can benefit from having their stomach removed. And the stomach is removed in an operation that looks similar to a gastric bypass, where we create a very small pouch at the top of the stomach, bring intestine up. So if you look at the diagrams that you'll see on your screen, the food is coming down the food tube into the small pouch and directly into the intestine. It never enters the stomach. And that stomach is then removed so that it can't cause any of the symptoms the patient has. This has also been studied pretty more aggressively now that we're seeing more patients for gastroparesis therapy, and it can work very well. Is this a first-line therapy for most people? I don't think so. I think most people are going to get better without it. This is really a therapy as an end stage, highly effective, but there's some management involved. Those patients who require this therapy will behave very similar to weight loss surgery patients. And generally speaking, somebody who gets this therapy, they don't need to lose weight, right? That's not the problem. The problem is that they can't keep their weight on. And so we have to work pretty intensely with those folks. And they're diabetics, so they're going to see a dramatic alteration in their insulin metabolism. They're not going to be hungry, so we really got to help them. If the patient has a jejunostomy tube already, we'll keep it to help them through the adjustment period. But people are getting admitted every month to the hospital for severe symptoms. We can make that better. And this is a good therapy for that in the right patient. And so it's a big therapy though. And I don't think the patient comes to the office the first time and we sit down and say, hey, you need to have your stomach out, right? It's a process, and it's getting to know one another, understanding what the disease is, trying some therapies. And if somebody gets that, it's great, and it works well, but in my opinion, not a first-line therapy. So a final therapy that's surgical that we offer for gastroparesis is actually gastric bypass, which you are probably more familiar with in terms of weight loss. Paradoxically, we will see some patients with very severe gastroparesis, lots of nausea and vomiting, who are significantly overweight. And while sometimes people can't understand how that can happen, remember, gastroparetics, when they're able to eat foods, it's typically high calorie liquids and low fiber foods. Those tend to have a lot of added sugar, lots of carbohydrates, and for some people's metabolism, that will lead to obesity very, very quickly. And so we'll see a subpopulation who are obese or morbidly obese with a body mass index over 35 who need therapy for gastroparesis. And in that group, we'll offer them gastric bypass. And that's, you can see on your screen the picture of that. It looks very similar to the subtotal gastrectomy, except that we leave the stomach part in. This is well studied. It works very well. It leads to weight loss, which is much healthier for the patient. For the diabetics, it frequently leads to remission of their diabetes, their high blood pressure, their sleep apnea, and a resolution to the nausea so that, again, they're able to eat more normal foods, healthier, high-quality foods, higher in protein, some raw vegetables. And so we use that therapy in this group, and it seems to work well. It's a minority population, but still important to mention. And that leads us to a treatment algorithm, kind of how do we do it? So typically when we see a new patient, we're going to go through the dietary recommendations, refer them to a dietitian, take a good history. For the diabetics, once they've been through that, if they're not improved, we're going to offer them pyeloplasty and stimulator together. For the idiopathic patients, we're going to do pyeloplasty alone. Most people, 75-80%, are going to be good at that stage. For the folks that are still very symptomatic, still getting admitted to the hospital, having involuntary weight loss, we'll either progress to the addition of a stimulator for the idiopathics or to subtotal gastrectomy or gastric bypass. And that algorithm seems to work well. One, it gives people hope. We have a therapy at the end of the day that's going to get people to where they can eat again, they can enjoy their quality of life, and we're going to take it in a risk-averse approach, doing the least risk items up front, medium risk in the middle, and saving the highest risk items for those people who absolutely must have it. Okay, well, that wraps it up. I hope you've enjoyed the content today and it's been informative. If you have questions or comments, you can get me at my contact information, which will be on the screen, and we hope to hear from you another day.